Thank you for having me as a physician. What is probably not usual, and I will try to talk you through how we in brain surgery treat patients, how we rehearse procedures, and how we should in the future probably do such rehearsals. Now, bottom line is that brain surgery is not common surgery. That means whenever you look at the emergency room or whatever, you can be sure that those guys have never seen a brain surgery, because simply it looks like this, and this probably you have not seen on TV so far. So you have a microscope, and then you have magnification, and you have patients in all positions just to get to your target region. That means nothing looks like on TV, and they're not talking, and then they're not quarreling, and they're not touching themselves when they're not sterile. So everything is in a rather organized fashion. Now, there are a couple of techniques you need to perform brain surgery. Otherwise, you would do it in a way they have done it 30 years before. That means the first thing is you need to know where you're going in the brain, because in previous years, let's say 60s, 70s, they said, well, you need to feel it, yeah? Don't you feel the tumor, yeah? Can you imagine? Now, nowadays, what you do is you do neuronavigation, what is more or less the same like navigation in your car, just you don't have satellites, you have light-emitting diodes in the room, and you have the operating microscope with receivers. And by doing so, you can navigate in the dummy or in the brain, and the accuracy is roughly 1 millimeter. That means it leads you to the structures you want to find, and it leads you around the structures that you want to avoid. Let's say centers for vision, for movement, etc. So this again is your posture. This is navigation, and by doing so, you find your way through the brain. Even more, what you can do is that you can project all kinds of function into your imaging. Navigation works in a way that you have brain imaging, usually magnetic resonance imaging, and you navigate through the brain. You can project, for example, functional structures like the tracts that mediate motion or vision or whatever. And you can also project the centers responsible for speech and for other activities to avoid them during surgery. That means when you have this plan, then you can navigate not only morphology, but you can also navigate function. To add on, you see this is a brain tumor, a glioma, and you see that the borders are blurred. That means it is not like the tumor that you might have imagined. So it is a good question, where is the border of this tumor? In the imaging it's evident, in the brain it is not. So what you can do when you dim the light a little bit, you would see in fluorescence light under the microscope the brain turns blue, and the tumor is in this pinkish fashion, and thereby during surgery, you can more or less illuminate the tumor, and by doing so, you can dissect around its borders. Even more, what you can do is you can do intraoperative MR. That means you're doing tumor surgery, and when you think that you're done, then you can drive the patient with the open head just a few meters down the line into a sterile MR, check whether you have taken out the tumor. If not, you continue surgery. If yes, then you close the head. So you see, this is the operating table, and just from here to here, this is the path into the MR that is situated inside the operating room. Even more, what you can do awake surgery. Now, this is not for every case, but of course there are functions that you can monitor during surgery. For example, speech. How do you want to monitor speech? You cannot. Yeah? So what is helpful is when the patient is awake, indeed. Now, this is how they did it in Montreal in the 1950s. This is a technique that has been around for quite a while. And if you look at this, for example, now, these are the hands of the surgeon. This is the sterile barrier, so to speak. This is the open head. This is the brain, and on this side there is the patient playing guitar. This is the non-sterile guitar. So all kinds of tasks can be imposed when you want to monitor a function that is complex and that cannot simply be monitored by doing electrophysiology or whatever. An important point, of course, is that this is not an emotional burden for those patients, but more than 90% would do it again, so to speak. That means you do some rehearsal of the procedure. So the day before, you bring him to the OR, show him how he's gonna wake up, and tell him what tasks he's supposed to do the next day. And people usually get along pretty neatly. What you can do to add on is, of course, that you can try to monitor vascular anatomy. So you can bring large angiography machines that more or less function like the robot arms in the automobile industry into the OR, and by doing so you can also monitor vascular pathologies. Is the aneurysm closed? Are the arteries open? And so forth. And this is of major importance because the ischemia time in brain is very short. So when you occlude an artery that is not supposed to be occluded, once you have noticed it after surgery, the patient has stroked several times. But anyway, brain surgery, of course, is surgery in a way. So it's not applied technology by an assistant, but still it is something that you need to train. So with the best machine, and a clumsy surgeon remains a clumsy surgeon, so to speak. Yeah? That means when you want to train this, you usually have labs, and those labs are more or less resembling the operation room in a difficult degrees of accuracy. So they are now under the microscope training to do suturing for bypass surgery, for example. You see they're training in a non-sterile condition, but this suturing is very complicated because the threads are thinner than your hair. So it takes quite some time to accomplish this. Once you've accomplished your training in the rubber tube, then you can go to the chicken leg. The chicken leg is the most famous and most reliable training model for everybody who does micro bypass surgery, because the arteries of the chicken leg are exactly like the arteries of the human brain cortex, and you can do hundreds of anastomoses, and in the end you get the manual skills, of course. In the end, when you have done your manual part, so to speak, then you want to go into the animal model, not every day, but in, let's say, regular intervals, because this gives even more. It can show you whether your bypass will be sustainable, or whether it will thrombose, for example, when there is a flap, or when you have done something wrong, when you've touched the artery from the inside, whatever you may go wrong. What is not what you cannot find out from the chicken model. But of course, it only makes sense when you're skilled to this level. Otherwise, you would sacrifice animal life. Now, this is a human hair, and this, for example, is the thread that you need for bypass surgery in the brain. So it's more than of course, it makes sense to train it beforehand, like all the things that should be trained. There are, of course, some let's say cerebral capabilities that cannot be trained. When you want to do complex brain surgery, then you should be ambidextrous, should train everything, do it with both hands, of course, depending on the angle, depending on the surgical field. There are guys around, of course, that can do things probably that you can never train in your life, at least not in this accuracy and not at that speed. Yeah? And you can take this to any further level. So that means that the connectivity across the corpus callosum in some people might be faster or better than in others. Yeah, hi. So she's unfortunately not a neurosurgeon, but this would be the ideal person. Now, talking about the procedures, exposures, everything means that you need to arrive in the brain at that point that you want to go, and you need to arrive there without fatiguing yourself. So patient positioning can be a very, very long process, taking 1 hour, so not like in abdominal surgery, for example, but you need to arrive exactly at the point where you want to arrive. Otherwise, you need to touch the brain, and then you hurt the brain. So you need to train this. Having simulators around makes sense, and surgical simulators more or less have often been compared with flight simulators. What is only true, well, not really. Yeah? That means, of course, New York is always in New York. So when you train flying to New York, no problem. Yeah, the patients are every day something else, and they have their individual anatomy. So you have to train it individually, so to speak. It makes sense when you're simulating something that the environment is very much like real life. So if this is a simulator, if the simulator would look like a kitchen or like an like a desk, then they would not take the simulation seriously. So when you do simulation, after 1-2 minutes, you must be in this world, and you must believe that this is real, and then simulation works, of course. And for example, this very famous emergency landing was possible because this particular airline trained heavily water landings with this type of aircraft. So that would probably would not have been accomplished by others. When you want to train brain surgery, now there are simulators. The most famous one, the Neurotouch, is a Canadian type by the company that is building the arm for the space shuttle. So they are skilled guys, yeah. But what they cannot do is they still could not accomplish simulation for brain arteries. So for the aneurysms, for aneurysm surgery, what is the most complex surgery that you can do? They could not simulate aneurysm ruptures. They could not simulate all the things that are interesting. They only could do brain surgery in a way that you could compare chief of the department with the resident, or you could compare 3 in the afternoon, 3 in the morning. You could compare with coffee, without coffee, all these easy things, yeah? But not aneurysm surgery. Now, this machine that it was an Upper Austrian effort, and this is let's say the first one that is capable of doing so, gives you the chance to do aneurysm surgery in this training environment, and you have the tools in your hand that you use for aneurysm surgery. So you have those arms that provide the haptic feedback that you need. So it's not just in a virtual space, but you get the haptic feedback like in real life. You have the original tools in your hand, like in the OR. You have a 3D environment, like in your with the operating microscope, and you can apply all the clips even more that you can use in real life for those procedures. Now, so this is Dr. Gmeiner trying to clip an aneurysm. You see the arms, you see the machinery. So in fact, this looks very real, and then the only drawback is that there is no brain, apparently. Yeah? So you're having naked arteries, but you can clip the aneurysm, you can rupture the aneurysm, you can stop the bleeding by clipping something, and once you have done so, then you can even evaluate the result by checking whether you have stenosed the artery, whether there is remnant aneurysm, and so forth. But still, this is only a training device. Now, what you want to do, of course, is to load tomorrow's patient. This is why I called it like this. Yeah? So when I know I operate this patient tomorrow and no patient in the brain is the same, I want to know how to treat this particular aneurysm to reduce morbidity. This is what the simulation allows, clipping and then checking the flow afterwards. But of course, what you want to favors the prepared mind. So when you know how it's going to look tomorrow, when you have chosen the implant for tomorrow, the day before, when you go in prepared, your surgery will be more successful. Now look at this, for example. This is how it looked during surgery. I took this case. So it's an aneurysm. It's more complex because there is a branch you see, and that the clip has a hole. It's a fenestrated clip, and the aneurysm has been clipped. So these are the arteries in the brain. This is how it looks under the microscope. This is the aneurysm here. It has been clipped, and this branch through the opening has been reconstructed. And these are the pictures from the simulator taken the day before. Now, of course, what you see is that by the degree, you could predict at which angle you want to approach this aneurysm, which clip you want to use, what is the result. Now this, of course, is simulation that takes it to the next level, and you can take it even further. And this is the topic of a joint effort that we have here in Upper Austria, together with Professor Meyer, for example, and with others. This is a consortium that is trying to build something like a hybrid simulator. I showed you the drawback was that you could do all these procedures on naked arteries. Yeah, so you have a hole in the brain and in the skull, and inside the skull there are arteries. What is not the case? We have brains, and inside the brains there are the arteries. Now, to get this simulation to the level where we can simulate both the arteries and the brain, we're trying to build this kind of simulator that has been termed the Medusa. That means you have a haptic model, and this haptic model is blended with the animation that I showed you to give you both the haptic feedback and the virtual simulation that I tried to outline. So you have the virtual part, so to speak. You simulate only the haptics, and you can assess what you have done, all those flow. analysis. When you have only a haptic model, well, then you can flip on plastic, what doesn't make sense in the year 2020. But when you combine it, of course, you have both the virtual and the real aspect. That means the haptic feedback is real. On the other hand, you can assess what you have done from a hemodynamic standpoint by checking your computer model. Thank you very much.